Good afternoon. Quickly, before I start my talk, while they're connected, I can kind of show you what we did in the CTO case in the morning. Can we have those images going up? So where we left you was where we crossed the CTO with a wire here. Go next. Can you play these images and go next? So here we had a parallel wire which had gone in, and then we sacrificed the original wire. Next. Yeah. Unfortunately, the IVIS did not work because there was a loose connection, so we couldn't do an IVIS, but we did it in the conventional fashion. Should I just go to the talk and then come back later, or do the talk? Yeah, okay. Connect me to the talk. Get my slides up. So the purpose of these next few minutes is going to be just to impress upon you the utility of imaging tools like FFR and IVIS in today's practice, and I think it's very important that we use these tools to the maximum. Yeah, just push it back in. Yeah, it'll take time. It'll come. Yep. Great. So just very briefly, the first case, I mean, we all know this data, and I'm going to let go of all these slides. But it's a class 1 indication, and here we have a triple vessel disease, as the disease is highlighted here. And this patient came to us with stable angina with effort tolerance and a EF of 50%. Basically, is it multivessel angioplasty or bypass surgery? And what we ended up doing is this is a right coronary artery which is totally occluded, and you can see that the LAD is giving collaterals to it. So what we do in our practice is we do an FFR, and you can see the FFR in the circumflex is 0.86, the FFR on the LAD is 0.71, but you've got to remember that this LAD is supplying the LAD territory, and it's also supplying the RCA territory. So what we do in our practice is we open up the right corner, we open up, So we open up the CTO in the right coronary artery, and the CTO is opened up, I was guided. And once we open up the CTO, then we do a FFR again in the LAD, and the LAD has become negative. So it's now 0.83. So FFR and IVIS together helped us do the right culprit artery for this patient, left all the other lesions okay, and that is exactly what the Syntex trial told us, that if you end up putting multiple stents in arteries in multiple places, then the more stents we do, we'll have higher MACE rates and complications and higher TLRs, and so we've got to restrict them to where it's functionally required and not just about everywhere. And I think we demonstrated that in the morning in the case as well. And this is a similar patient. Again, and I don't want to repeat the theme. For lack of time, we'll kind of move ahead. And this is an important slide. When you start using more stents in patients, as you go up to 5 stents and 7 stents, you remember that your MACE rate and your TLR rates are going to be fairly high. And that is what makes angioplasty look bad against surgery. And that's very important. And let's talk about IVIS. And talking about IVIS, I think we'll have some introduction of some concepts. And what is a concept? What is a plaque burden? A plaque burden is a single frame analysis of the percentage area of the atheroma vis-a-vis the reference area. So when you look at plaque area, the orange area is the plaque burden for that particular segment. Now, if we took a few segments together and developed the volume, then you could have a plaque volume, burden of plaque volume in that artery. And this is a very important concept because it is a plaque burden in our country which is very high. And what I was taught as a medical student was our arteries are small. Our arteries are not small. They are overburdened with atheroma, and therefore they appear small on a luminal angiogram. But actually, when we do IVIS, we still see very large arteries with a huge plaque burden. And when the plaque burden is high, it increases MACE rates and TLRs, especially when associated with angioplasty. Is this synonymous with percentage stenosis? No. Percentage stenosis is a luminal diameter comparison of the reference vessel diameter to the stenosed area. So basically, when you have a tight narrowing, that diameter compared to that is percentage stenosis. So do not mix up the two issues, okay? So what does IVIS do? It helps you the concept of a landing zone. The edge of a stent is important. The importance of the edge of the stent is so much that if you land the edge of the stent in a plaque burden, which is more than 50%, you're going to have restenosis and you're going to have a high rate of stent thrombosis. As against this, if you land the edge of your stent in an area which is less than 50% plaque burden, then you're going to have low MACE rates and low TLR. Now, what happens in a diffusely diseased artery when there is no area of plaque burden of less than 50%? These patients, best you don't put in stents. You just do a balloon angioplasty, a drug-eluting balloon, and get out if it is an acute coronary syndrome. Or I think surgeons have a better handle because they will give a lesser TLR and a better long-term result because they have the weapons of endarterectomy and things in those patients. So that's important. Stent sizing, as I told you, the MLD of a landing zone is fine, but you can also size the stent. The stent can be sized appropriately, and often in our practice we've seen that we've undersized stents in our country. And we'll talk about it. And apposition again. Going to cases. And this case actually gives you the entire theme and the concept. This is a 75-year-old lady who had an acute coronary artery syndrome. She had non-ST elevation myocardial infarction anterior wall. This was 3 weeks prior to this angiogram. She has unstable angina now. She walks like around 50 meters and gets chest pain. So this is the angio. Would everybody in the audience agree that currently we should put in a stent between the two arrows? Or would somebody think otherwise? So I would say that most people in this country would have put in a stent between these two arrows. But is that how I look at this artery? Probably not. So when I look at this artery, I look at the two arrows, and the distal arrow is the right frame and the proximal arrow is the left frame, and you find that the minimal luminal diameter at the landing zone is around 2.1 and 2.6. So what does it mean? That means you can, at the most, in this area, put in a 2.5 millimeter long stent. If you try to put anything bigger than that, you'll have an edge dissection because it'll undermine the plaque beyond and before. So here you have an inflow which is 2.5, but the inflow of the stent is going to be in an area which is a plaque burden, which is right at the right frame, of almost 60% to 70%. So you are putting in a long, small stent in this 75-year-old lady. How do I look at the coronary artery with IVUS? I go forward and I say, where is a landing zone proximally less than 50%? It's right at the left main. And therefore, instead of stopping short in the proximal LAD, in this particular patient, I would go ahead and stent all the way into the left main and give her a 4-0 artery going into a 3.5, going into the 3-0, and landing into a 2.5. This patient is now 15 months out. She has no angina, her stress thallium is negative, and she's okay. Now, this is the concept, and this is how IVUS changes practice, and this is an important concept. Because when you say the surgeons, they say they put a lima to the mid-LAD. And when you put a lima to the LAD, that's fine, because if you have any acute coronary syndrome from the proximal LAD, the lima prevents and possibly prevents a fatal MI from that closure of the acute LAD in the proximal segment because it covers an entire expanse of area. The same concept applies with angioplasty. You have to learn to pacify the proximal LAD as well, unless it is non-flow obstructing. And if you have a distinct path where you have a landing zone which is 50%, and if you have a remote lesion which is not significant, do not touch it. But if it is in continuation, then I think you should capture it. Let's go to the next. I mean, this is something I've talked about in the past, but let's not go into this complex angioplasty. But when you do these calcified bifurcations, it tells you amazing information about the carina, which is in the circles. You can see the carina on the top, which is in the circumflex, tells you that the carina is free from disease in the proximal, in their distally, and in the LAD circumflex bifurcation, the carina is full of disease. So here it will have to be a bifurcation stenting. Okay. This is how we do a rotablator into both these arms, and we figure out that the yellow boxes show areas which have deep calcium, and they require high pressure dilatations with a cutting balloon. And after that, you put in a stent, and this is the final result you get. However, in this particular patient, in spite of putting a 4-0 stent, intravascular ultrasound of the proximal LAD showed that I was able to expand it only to 2.25 or 2.4. That means in spite of using a 4-0 stent, we could expand it only to 2.5, under expanded. I knew at that time that this is a high chance of a TLR. This patient came back and ended up having surgery at the end of 7 months. So we know that. Now, as against that, if you look at this diffuse calcified lesions, in this calcified lesions, all options gone. Post-surgery, lima is already wasted in this artery. You can see the diffuse disease. So what do we do? What is the safest strategy? When you do an IVUS, you can realize that the left main is 6 millimeters. Then the confluence is around 5.9, again 6. And when you look at the confluence and the two arteries, both the arteries are around 3.25 millimeters. How can you take a 3.0 millimeter stent and expand it to 6.0? You cannot. So here, the strategy is important, and we did a V stenting. This is the picture after rotational atherectomy of the LAD and the circumflex artery in 2 different stages and reconstructing it. And this is a 18-month follow-up angiogram on this lady, as you can see there. 18 months later, she went for a bilateral knee. So it happens to be a doctor's arm, so we did an angio, and this is the long-term patency of this result. Calcified left mains, again, what is important is sometimes you see a ring of calcium. Now, the ring of calcium may be 2.5 millimeters, and so rotoblator won't help. But it is important to fracture that rim. Unless you fracture that ring, as you've shown over here in the right picture, you will not be able to expand a stent. So fracturing a rim in a IVUS is extremely crucial to get a good stent expansion. And then you get a great expansion. And this is the rule of thumb. When you use a 2 millimeter stent, you need to have at least a 3.1 millimeter square cross-sectional area of the stent. So when you use a 3 millimeter stent, it has to be 7. When you use a 4 millimeter stent, you have to get a 12.6. If you do not get this, that means you have done a suboptimal result. So when you do an IVUS, you've got to make sure that the stent, you think that you put a 3.0 stent and you got a great result. But if you do an IVUS, you'll often find that even though the 3.0 is actually not 3.0 and just 2.2, you've got to take gradual balloons, higher pressure, and make them circular and higher cross-sectional areas. That's important. I want to show you one case in an ST elevation myocardial infarction. 85-year-old came in with an ST elevation. All of us say that this is, how many of us would involve the ostium of the LAD in this angioplasty? Most of us probably would put a stent in the mid-LAD, in the culprit area. But this is how we look at it in IVUS. This is the IVUS vision of this artery, the longitudinal pullback. And then you have the culprit lesion, which is represented here. And you have this distal area where we found a flap. And when you look at this, as against what we did today, if you were to put a discrete stent in the proximal LAD here, in the mid-LAD, your edge of the stent would be at a dissection flap, which you would have missed angiographically. And you can see, and the proximal part is here. So here is the edge. Can you see a flap coming in right over there? Can you see that flap? And here is a frozen picture of that flap. You couldn't miss it. You have to cover this with an angioplasty when you're doing a PAMI. And when you look at the ostium of the circumflex and the LAD, you can find that these are heavily calcified arteries with areas of less than 2.7 millimeters square. And therefore, you have to do this left main along with it, or this man will keep on having angina. So this is what we did. We did a bifurcation stent. This is the end result of that patient. And he's now almost 2 years post, and he's doing well. I want to show you one last case in keeping it simple. This is a patient who was referred to me for a rota LAD and a rota circumflex. And we can see that the ostium of the LAD is diseased, and it was said 60%. When we look at the IVUS, we find that we do a rota based on the IVUS. We plan the stent in the LAD. We plan the stent in the circumflex. We do a rotoblator, then we do a flextome balloon. And this is the ostium of the LAD. When you look at the ostium of the LAD, you can see that the area of the LAD is around 6.8 millimeters square. 6.8 millimeters square on IVUS is never FFR positive. These people are not going to have angina. So it is best to leave it alone. And so when you start your rota burr, take your rota burr beyond the ostium and activate the burr beyond the ostium. If you activate it in the left main, you'll scrape the LAD, and then that will be a problem. This patient, we did a rotational atherectomy. We put in a stent, and once we put in a stent, this was a final result. We found that the distal edges were great. The plaque burden in one spot was more than 60%, so we gradually went up with larger balloons and expanded it to optimal. And this is the long-term, this is there's a 15-month follow-up angiogram on this patient that was there, and you can see that the ostium of the LAD is perfect, and this patient is asymptomatic. We can show you cases and cases, but basically, this is on instant restenosis that we've learned that what we did 10 years ago, we put in a very small stent in a large artery. That's because we didn't have